Uterine fibroids, also called fibromyomas, are benign tumors that develop from the uterine muscle. They represent the most common pathology in women during their reproductive years. The diagnosis of uterine fibroids is based mainly on pelvic ultrasound, which allows detection of tumors and assessment of their size, number, and location. The treatment of uterine fibroids primarily aims to control blood loss, correct anemia, and manage the fibroids themselves. In some cases, a conservative approach is adopted, known as therapeutic abstention, where no active treatment is given and only regular ultrasound monitoring is performed to observe the evolution of the fibroids over time. Medical treatment may include progestins administered from day 16 to day 25 of the menstrual cycle, which have a strong atrophying effect that helps reduce endometrial hyperplasia responsible for menorrhagia. However, they do not reduce fibroid size and are contraindicated in submucosal fibroids because they may worsen bleeding. Another option is GnRH agonists, LHRH agonists, which induce reversible medical castration, leading to a reduction in fibroid volume and decreased bleeding. They are mainly used preoperatively for a limited duration to correct severe anemia, facilitate surgery, or modify the surgical approach. Additional treatments include iron therapy to correct anemia caused by significant blood loss, as well as uterotonics, hemostatic agents, and venotonic drugs, which are used in cases of heavy bleeding to control hemorrhage and improve venous circulation. Surgical treatment of uterine fibroids includes two main approaches: conservative and radical surgery. Conservative treatment mainly consists of myomectomy, which is recommended in cases of a single large fibroid and can be performed either through laparotomy, an open abdominal surgery, or laparoscopy, which is a minimally invasive surgery, as well as operative hysteroscopy, which is used for the endoscopic removal of small intracavitary or submucosal fibroids measuring less than 4 cm, allowing the uterus to be preserved. Radical treatment consists of total hysterectomy, which involves complete removal of the uterus and is indicated in cases of multiple fibroids or when other treatments have failed. In premenopausal women, hysterectomy may be performed with or without bilateral salpingo-oophorectomy, meaning removal of both ovaries and fallopian tubes, while in women over 50 years old, bilateral salpingo-oophorectomy is generally recommended. After any radical surgical procedure, a pathological examination is essential to confirm the diagnosis and rule out malignancy. Embolization is a conservative method that treats fibroids without invasive surgery. This treatment leads to the disappearance of bleeding and a reduction in fibroid size. However, it is not recommended for young women who wish to have children, as there is a risk of premature ovarian failure if the embolization material affects ovarian blood supply. The indications for treating uterine fibroids depend mainly on symptoms, size, complications, and specific clinical situations. In asymptomatic fibroids, smaller than 10 cm, management is usually conservative with therapeutic abstention and regular follow-up every 6 months using ultrasound. In symptomatic fibroids, treatment varies according to severity. For moderate-sized fibroids, medical treatment is generally the first-line option, except in cases of submucosal fibroids where it may be ineffective. For large or complicated fibroids, submucosal fibroids, or when medical treatment fails, surgical intervention may be required. If surgery is contraindicated or in cases of significant hemorrhage, uterine artery embolization can be used as an alternative to reduce fibroid size and control bleeding. In cases of fibroid undergoing necrobiosis, medical management is prioritized, including hospitalization, bed rest, analgesics, and anti-inflammatory drugs, including corticosteroids during pregnancy if needed, and broad-spectrum antibiotics to prevent infection. If the fibroid remains large after 3 to 4 months, elective cold surgery may be considered. During pregnancy, fibroids are generally left to evolve naturally unless they are in a previa position or obstruct fetal delivery, in which case intervention may be necessary. Oral contraceptives are not contraindicated in women with fibroids, whereas large submucosal fibroids and a polymyomatous uterus contraindicate the use of an intrauterine device due to potential complications, and hormone replacement therapy during menopause is not contraindicated even in the presence of fibroids. Thanks for watching until the end, and don't forget to like and subscribe for more videos.